In this lecture, we're going to cover the urinary system. Functions of the urinary system include excretion, elimination, and homeostatic regulation of blood plasma. Excretion is the removal of organic waste products from body fluids. Elimination is the discharge of waste products into the environment. And homeostatic regulation of blood pressure is regulating blood volume and pressure, regulating plasma ion concentrations, stabilizing blood pH, and conserving nutrients. Looking at the structures, we have the kidneys, which of course produce the urine. Tubes coming out of the kidneys are going to be the ureters, and the ureters go down to the urinary bladder, and they're going to transport urine from the kidneys to the bladder through peristalsis. And the bladder is going to be the temporary storage house for urine, and then the urethra is what conducts urine to the exterior. If we look at the position of the kidneys, we can see they're just below the floating ribs here. The floating ribs kind of cover them a little bit. And you can see we're at L1 level. So the left kidney is going to be raised up much higher. As you can see, it's under two of the floating ribs, 11 and 12. Whereas the right kidney is pretty much the top of it, top half of it is just under the 12th rib. So you can see that the right kidney is lower than the left kidney. And through this cross section here, we can see the kidney, the renal arteries and veins, this adipose capsule which surrounds the kidneys to kind of help hold it in place and give it some cushioning and protection. And this is also a type of fat called brown fat, so it's a little bit more metabolically active, and so it'll also give a little bit of heat to the kidneys as well. Here you can see the aorta and the inferior vena cava. The aorta is going to give rise to the renal artery. The renal vein is going to cross over and hook up with the inferior vena cava. And you can see that here as well. Here's the renal arteries. Notice the left one's a lot shorter. The right one has to cross over the body. The inferior vena cava, again, is going to take on blood from the renal vein. On the right, it's shorter. On the left, that renal vein is much longer. And if you ever do cadaver work, just know that the renal vein is going to be on top of the renal artery. And so again, we see the right and left kidneys. We can see the adrenal glands sitting on top of the kidneys. Here's the renal veins, again, sitting on top of the renal arteries. And here are the renal arteries coming off the aorta, and the renal veins feeding into the inferior vena cava. Here again are the ureters coming down to the urinary bladder. Now, if we do a coronal section through the kidney, we can see that there's going to be a superficial outer cortex and an inner medulla. The medulla consists of 6 to 18 renal pyramids. And the cortex, remember cortex means bark, like on the bark of a tree. So it's the outermost layer. The cortex is composed of roughly 1.25 million nephrons. We're going to have what are called major and minor calyces along with the pelvis, which drain urine into the ureters. And so looking at this, we can see the cortex. This is the medulla. So all this is the medulla, and the medulla is going to create these renal pyramids. And again, the renal pyramids are going to drain into, this will be a minor calyx. That then drains into the major calyx. And the major calyx drains into the renal pelvis, which then drains into the ureter. Surrounding the kidney is going to be a renal capsule. A renal lobe is where we go in between these columns. These are renal columns. And so it'll be a half of the renal column on each side. It'll be some cortex, and it'll include part of the medulla and the renal pyramid. And again, you can see the kidney here, an actual cadaver kidney. Now, blood supply to the kidneys. Again, off of the aorta, we're going to have the renal artery. That then is going to feed into a segmental artery, then an interlobar artery, then arcuate arteries, then interlobular arteries, and then we'll have a branch that's the afferent arterioles, which then feeds the nephrons. So if we look here, here's that afferent arteriole. The nephron is going to be composed of a glomerulus. The glomerulus is a ball of capillaries. This is where filtration takes place. It then drains away from the glomerulus through the efferent arteriole, then into the peritubular capillaries, then into the venules. So let's pick up back here, venules, into the interlobular veins, then the arcuate veins, then the interlobar veins, then finally into the renal vein, which empties into the inferior vena cava. So again, renal artery. Here's the segmental arteries, then the interlobar arteries, then the arcuate arteries. Coming off of those, we can see a little better over here, are the interlobular arteries, and then the afferent arterioles. Coming off of that, going to these little things are where the glomeruli are. Okay. And then coming back, we have the interlobular veins. Of course, this is after the venule. So the interlobular veins, we have the arcuate veins, the interlobar veins, the segmental veins then feed into the renal vein, which then empties into the inferior vena cava. Now this is a typical nephron. Now it's been kind of stretched out to go in kind of a linear fashion. In reality, this will be kind of folded over on itself, and so that the distal convoluted tubule here will actually come up backwards and come up and press up against this area here. We'll see a better representation of that later, but just to put it kind of in a nice, neat, orderly way to remember all the parts, we've done it this way. So we have the renal corpuscle here, and the renal corpuscle is going to be made up of the glomerulus, which is a ball of capillaries. And again, this is where filtration takes place. And then here is Bowman's capsule. And it would be like this. If you took your fist and pushed it into a balloon, and your fist would be the glomerulus, the balloon would be like Bowman's capsule. Okay, now imagine your fist secreting Okay, you know what? Don't imagine your fist secreting something. That would just be creepy and pretty gross. So forget I even said that. But just think about your fist being the glomerulus. The glomerulus, through filtration pressure, which is from blood pressure basically, the blood pressure, if it's high enough, will help push solutes through little spaces that we'll look at later in the glomerulus and into Bowman's capsule. From there, we have the proximal convoluted tubule. We have the loop of Henle, which is going to have a descending limb of the loop of Henle. Here's the loop. Here's the ascending limb of the loop of Henle. And then here's the distal convoluted tubule, and that is going to feed into the collecting ducts. And multiple collecting ducts will feed in together here into the papillary duct, which delivers urine into the minor calyx. Nephron functions include production of filtrate, reabsorption of organic nutrients, reabsorption of water and ions, and secretion of waste products into the tubular fluid. There's going to be two types of nephrons. There are cortical nephrons and juxtamedullary nephrons. Cortical nephrons represent about 85% of all nephrons. They're located, of course, in the cortex. The juxtamedullary nephrons are closer to the renal medulla. Part of it is in the cortex. The majority of it is down in the medulla. And the loops of Henle extend deep into the renal pyramids. Here we can see the cortical nephrons, where the bulk of the nephron is found within the cortex. The juxtamedullary, we have some in the cortex, but the bulk of it is going to be down in the medulla within the renal pyramids. And again, you can see the collecting duct and these papillary ducts emptying into the minor calyx. So again, these are cortical and juxtamedullary nephrons. And so looking at the cortical and juxtamedullary nephrons, in this cortical nephron, we can see the afferent arteriole feeding into the glomerulus. Leaving the glomerulus is the efferent arteriole. Then we're going to have these peritubular capillaries, which are going to surround basically the proximal and distal convoluted tubules, and also the loop of Henle. A little bit different over at the juxtamedullary. We have the peritubular capillaries, okay, and they're going to be surrounding the proximal and distal convoluted tubules. Then we have what's called the vasa recta, which surrounds the loop of Henle. Taking a closer look at the renal corpuscle. Again, the renal corpuscle is made up of the glomerulus and Bowman's capsule. Once again, if you think of the glomerulus as your fist, Bowman's capsule as a balloon, and you push your fist into it, you can see how it would just kind of wrap around it, and it's going to give this space right here. So as blood flows in through the afferent arteriole, notice too that there's some muscle here, so we can control the flow, obviously not voluntarily, but the body can control the flow of blood going through the afferent arteriole. And that's one of the ways the glomerular filtration rate is regulated, and that is how much blood actually flows through the glomerulus at a particular given amount of time. We'll talk about that a little bit later, but we have that. Here's the afferent arteriole, and then we have this region here that's called the juxtaglomerular apparatus, and that's going to be made up of the macula densa and the juxtaglomerular cells. and we'll talk about its function too a little bit later. Surrounding the glomerulus are these podocytes. These are the podocytes. And what does pod mean? What doctor do you go to if you have a foot problem? A podiatrist. So podo means foot. And so you can see these cells, these podocytes, have little feet. These little feet are called pedicels. And see, when they interdigitate with one another, they create little slits. So it's kind of like if you put your fingers together, there would be little slits there. And let's suppose you do that. You put your fingers together, like we're seeing right here. And someone has a bucket that has water in it, maybe some rocks, maybe some sand, and they pour that through your fingers. The water, of course, is going to flow through pretty easily. The sand will probably go through as well. The rocks will stop and, are held back by your fingers because they're not small enough to pass through these little openings or slits you're creating with your fingers. Well, that's what these pedicels are creating. They're creating these filtration slits. And so larger proteins, red and white blood cells are not going to pass through those slits. And again, just to show a little more close-up view of that under electron microscope, you can see the podocytes and the little filtration slits that they're creating with their little pedicels. Now, functional anatomy of the nephron. The proximal convoluted tubule, which is right here, actively reabsorbs nutrients, plasma proteins, and ions from filtrate, and it's released into the peritubular fluids. The loop of Henle, which is down here, we have a descending limb, the loop itself, and an ascending limb, and both limbs have a thick and thin part, and that's going to determine what is going to pass through, whether it's just water, whether it's just solutes, or so on. Now the distal convoluted tubule is over here, and it actively secretes ions, toxins, drugs. It reabsorbs sodium ions from the tubular fluid. Principles of renal physiology. Urine production maintains homeostasis. It does that by regulating blood volume and composition. It also excretes waste products such as urea, creatinine, and uric acid. The basic process of urine formation. We have filtration, and this depends on blood pressure. This is why we worry if a patient's blood pressure drops too low. If that happens, there's not enough filtration pressure for the kidneys to actually work, and the patient goes into renal failure or kidney failure. Also with filtration, we have water and solutes are going to move across the glomerular capillaries. Reabsorption is the removal of water and solutes from the filtrate. And secretion is transport of solutes from the peritubular fluid into the tubular fluid. Carrier-mediated transport. Filtration in the kidneys are modified by carrier-mediated transport, which takes into account facilitated diffusion, active transport, co-transport, and countertransport. And carrier proteins have a transport maximum that we abbreviate as TM. And this is going to determine renal threshold. Reabsorption and secretion is accomplished via diffusion, osmosis, and carrier-mediated transport. The TM determines a renal threshold for reabsorption of substances in tubular fluid. So an overview of urine formation, and I don't mean FYI for your information, this is for urine formation. Anyway, we have filtration that takes place in the glomerulus. That filtrate enters Bowman's capsule. In the proximal convoluted tubule, we have some water reabsorption, and we also have some solute reabsorption. And we also have secretion. And it's kind of opposite of what you would think. Okay, I would think that this is secreting. No, it's the tissue is secreting back into the tube. We have reabsorption of water and solute from the tube back into the tissue. Looking at the descending limb of the loop of Henle, we have water reabsorption from the tube into the tissue. And in the ascending limb, in the thick area, we have solute reabsorption. Again, solutes are going to be transported out into the interstitial tissue. We also have solute reabsorption in the distal convoluted tubule, as well as secretion back into the tubule from the tissue. And we can have some water reabsorption in the collecting duct, depending whether or not there is the hormone ADH, antidiuretic hormone, present or not. If it's present, then we're going to get more water that is going to reabsorb back into the tissue and then into the bloodstream than if we don't have ADH. And then we also have some secretion, again, from the tissue into the collecting duct, and then some solute reabsorption. In this case, it could be urea, and we'll talk about why later, but urea being pushed into the tissue. So glomerular filtration starts off, of course, in the glomerulus. It's driven by blood pressure, which creates a filtration pressure to push solutes into Bowman's capsule. And we talked about the podocytes, and these are the pedicels, the little finger-like projections, creating filtration slits. Okay, those sit on top of the capillaries. And so we have little pores within the capillaries. And this is where the filtrate is going to be pushed through these pores, through the filtration slits, and then into Bowman's capsule. And the filtration pressure is about 10 millimeters of mercury pressure. Glomerular filtration rate, or GFR, is the amount of filtrate produced in the kidneys each minute. Factors that alter filtration pressure will change GFR, either increasing or decreasing it. So some factors that control GFR is a drop in filtration pressure that stimulates the juxtamedullary apparatus. And again, this is the juxtamedullary apparatus, which is made up of the macula densa and the juxtaglomerular cells. This then releases renin, and we'll talk about what renin does in a second here, and erythropoietin. Now, we've already learned about erythropoietin in a couple of systems. Erythropoietin stimulates the bone marrow to start to produce more red blood cells. So if your filtration pressure is down, that could be because of a loss of blood. So that's why we're secreting the erythropoietin to make more red blood cells. The renin is going to be part of what's called the renin-angiotensin-aldosterone system, and that is going to help raise blood pressure through vasoconstriction. So we can see here that if we have a decreased GFR, glomerular filtration rate, homeostasis is disturbed. Renin is released. Renin is going then to cause angiotensin activation. Angiotensin, kind of like the name says, it sounds like hypertension, right? Angiotensin constricts blood pressure, or constricts blood vessels down, which raises blood pressure. So we have elevation of blood pressure and blood volume, and that is going to increase the GFR, and homeostasis should be restored. And I love how these little headers pop up late. Sympathetic activation produces powerful vasoconstriction of afferent arterioles. Remember the afferent arterioles? We have some smooth muscle there. We can constrict that down. That would be like if you had a hose, a water hose, going into your garden. And if you took a clamp and you started screwing that clamp down onto the hose, the more you constrict the hose, the less water is going to flow through it. Same thing here. So it, again, decreases GFR and slows the production of the filtrate. It changes the regional pattern of blood flow, which also alters GFR, and it also stimulates renin by the juxtaglomerular apparatus. Reabsorption and secretion at the proximal convoluted tubule. Glomerular filtration produces fluids similar to plasma, but without the proteins. The PCT reabsorbs 60 to 70% of the filtrate produced. Reabsorption of most organic nutrients take place here. Active and passive reabsorption of sodium and other ions, and also reabsorption of water. And then secretion also occurs in the proximal convoluted tubule, the PCT. The countercurrent multiplication between the ascending and descending limbs of the loop of Henle, there's an osmotic gradient that is created there in the medulla. This facilitates reabsorption of water and solutes before that filtrate gets to the distal convoluted tubule. And this permits passive reabsorption of water from tubular fluid. So that's the loop of Henle countercurrent multiplication. Reabsorption and secretion at the distal convoluted tubule. The distal convoluted tubule performs final adjustment of urine. There's active secretion or absorption. Absorption, tubular cells actively reabsorb sodium and chloride in exchange for potassium or hydrogen ions, which is secreted. Okay, reabsorption and secretion along the collecting system. We have water and solute loss is regulated by aldosterone and ADH, antidiuretic hormone. Remember I said I like to call it the anti-P hormone. So we have reabsorption of sodium ions, bicarbonate, and urea, which are resorbed. And then secretion, pH is controlled by secreting of hydrogen ions or bicarbonate ions. In other words, if your blood is acidic, then you're going to pee out more hydrogen and retain more bicarbonate ions. If your blood is alkaline, then you're going to retain more hydrogen ions to acidify the blood and pee out more bicarbonate ions, which buffers the blood. So urine volume and osmotic concentration are regulated by controlling water reabsorption. The precise control is allowed via facultative water reabsorption. And so looking at the effects of ADH on the distal convoluted tubule and collecting ducts. With an absence of ADH, then water is able to flow freely through those collecting ducts. It's not going to be reabsorbed back into the tissue. So if you're very well hydrated, then your urine is going to be more dilute. Whereas if you're dehydrated, we don't want to pee out all of that water. That's going to dehydrate you further. So when ADH is present, and ADH is going to attach to what are called principal cells, that is going to make the collecting duct a lot more permeable to water. And because the tissue here, which we'll talk about later, is very salty, okay, there's a lot of sodium chloride here, it's going to draw the water out of the collecting duct, and you're going to get a smaller volume of urine, but it's also going to be very concentrated. It's going to be kind of that dark yellow to amber color. So when you see that, you know it's time to start drinking more water. The function of the vasa recta. This removes solutes in water, and it balances solute reabsorption and osmosis in the medulla. And so let's now take a look at a summary of urine formation. For your information. So let's take a look at urine production. So what enters Bowman's capsule? Well, cells and large proteins such as albumin should not enter into Bowman's capsule. It should not cross the capillary walls of the glomerulus. And when we talk about cells, we're talking about mainly red blood cells. Okay, white blood cells either, but especially red blood cells. They're a bit smaller. And again, those should not cross over. If they do, then you're going to have the presence of blood in the urine, which means there's some type of kidney damage going on. Okay. Now, what should enter Bowman's capsule, again, this is Bowman's capsule, is urea, water, salt, glucose, amino acids, and vitamins. Now, wait a second. You're probably saying, wait, glucose. I thought it was bad if you pee excess glucose. Well, yeah, that is true. You don't want to urinate glucose. That's usually a sign that there's the blood glucose levels are at a pretty high level, and you've reached a certain threshold where you're actually urinating out that glucose, and that's a sign of diabetes. Well, the glucose, the amino acids, and the vitamins, while they might be filtered out into Bowman's capsule, they're reabsorbed pretty rapidly. Okay, so let's take a look at see what's happening here. So filtrate enters the proximal convoluted tubule. So here's the proximal convoluted tubule. And it's going to have a concentration of 300 milliosmoles per liter. So what does that mean? Just think of it as a measurement of how much salt there is, okay, how much sodium there is, okay. So it's just a measurement of osmolarity, okay. It's like when we look at temperature, we might say it's, you know, 98 degrees Fahrenheit or 37 degrees Celsius. Well, what exactly is a Celsius? What exactly is a Fahrenheit? Who knows? Who cares? We know it's a measurement. What's a milliosmol per liter right now? Who cares? Look at the numbers. Okay. So we start off with about 300 milliosmoles per liter. It's going to leave the nephron with a concentration of about 1200 milliosmoles per liter. Now, this is going to be for concentrated urine. Okay. In other words, you're probably a little dehydrated and we need to conserve that water. Okay. So the urine is going to be more concentrated. You're going to get rid of a lot more solutes than you are solvent. In other words, you're going to retain more of the solids, or you're going to retain more of the water and excrete more of the solid stuff. Okay? And so the loop of Henle, which is right here, is going to function as what we call a counter current multiplier. It's going to increase filtrate concentration. And we'll talk about how in just a little bit. Now, the structure of the loop of Henle. The descending limb of the loop of Henle, right here's the descending limb. The cells are going to be flat. There's going to be very few mitochondria. There's going to be low surface area, and it's going to be permeable only to water. Okay, so what we're saying here with the few mitochondria, there's not going to be a lot of active transport. There's not going to be these sodium pumps and things like that. Okay, so it's only permeable to water. It's going to keep everything else in it. The upper portion of the ascending limb, and that's this thicker area here, the cells are cuboidal. There's going to be many mitochondria. There's going to be high surface area. And since there's a lot of mitochondria, that means we're going to have some active transport, and that active transport is for salt, sodium. Okay. And so filtrate enters the proximal convoluted tubule, the amino acids, the glucose, and some ions are released back into interstitial fluid and then reabsorbed back into the bloodstream. And then as the filtrate enters the descending limb of the loop, water is going to leave the loop by osmosis, increasing the concentration of the filtrate. So you can see water leaving. So water is getting drawn out through osmosis. And remember, osmosis is the movement of water through a semi-permeable membrane, okay, that's the cells, from an area of low concentration of solutes again are the water magnets, to an area of high concentration of water magnets, which means the tissue here, the interstitial tissue here, is going to be saltier, for a lack of a better word, than the saltiness inside the loop here. So since it's saltier out here, it's going to draw that water out. Now, as it draws the water out, the water is leaving, but the solids are going to be left behind, and we're going to get a more concentration of those solutes. Okay? So the solutes are becoming more and more concentrated. It's like if you're cooking. If you're making, I don't know, a soup or something, and maybe at the very beginning of making the soup, you put in enough salt in there where it tastes good. And if you do any cooking, you know that's a bad idea, because as you cook and reduce that soup, you know, so that it's not all watery, you're evaporating off the water. It's going down in volume, it's beginning to get a little thicker. Now if you taste it, it's going to be way too salty because you've concentrated that salt. Okay, you've gotten rid of some of the liquid volume. That's what's happening here. We're drawing the water out of this descending limb of the loop of Henle, concentrating it down to 1200 milliosmoles per liter. Okay. Now in the ascending loop, sodium chloride is pumped out by active transport into the interstitial fluid. So once again, I said, why is this interstitial fluid saltier than what we find inside the tube? The reason why it's saltier is because in this area here, we're pumping the sodium out. Okay, does that kind of make sense? So if we're pumping sodium out right here, sodium chloride out right here, this is going to be all salty. This is going to draw the water out, and it's going to concentrate the urine. As we come back up, we hang on to the water, but we start pumping out the solutes, the sodium chloride. Okay, which means now think about that soup. We've decreased the volume of the soup. Now it's too salty. Let's pretend that we could reach in there and start pulling the salt out, but leaving the soup behind. You'd still have as much soup left, but there would be less salt in it. Okay, obviously we can't do that, but that's what's happening here. We're actively pumping out the sodium chloride. So while we have the same amount of fluid as we do here, it's less salty. There's lower amounts of solute in this fluid. So as we're pumping out the water, now we're diluting down the filtrate. And up here, we have in the distal convoluted tubule, we're already down to 200 milliosmoles per liter. Okay, so let me read this again. In the ascending loop, sodium chloride is pumped out by active transport into the interstitial fluid. It establishes an osmolarity gradient, causing water to leave the descending loop by osmosis. So we make the tissue salty, sucks the water out of the descending limb. This is our counter current multiplier. So in the collecting duct, and this is the collecting duct, this is what all these tubes are emptying into. Okay, the water leaves due to sodium chloride gradient. Okay, now let me be a little more specific here. The reason the water is leaving in the collecting duct is because this person is dehydrated for whatever reason. And so ADH, antidiuretic hormone, is going to be released. And as it says here, principal cells in the collecting duct reabsorb more water when ADH is present. So in this case, the ADH, the antidiuretic hormone, is present, and it's allowing for more permeability of that water. And since there's more permeability, it's going to get sucked into the interstitial tissue here because of this sodium chloride being pumped out into the tissue. So what's happening is we are beginning to concentrate the urine once again. So at the lower end of the collecting duct, some urea leaves because, see, once we pass this area, we're no longer pumping out sodium chloride, so we need some other kind of solute. So we pump out some urea, and that acts as a water magnet now to pull more water out of the collecting duct. Okay, so again, some urea leaves, which further increases the concentration gradient in the inner medulla, allowing water to leave the descending tubule. And then urea can then re-enter the filtrate at the ascending tubule. So obviously we don't want to keep absorbing that urea. So we're going to reabsorb the urea to get rid of it. Now let's suppose, oh, well, here, let me just finish here. So we've concentrated this urine down to 1200 milliosmoles per liter. Okay, and then when you pee, you're going to notice it's darker in color. It's going to be maybe a dark amber color. Okay, that means you need to drink more water. Okay, so let's suppose you're very well hydrated. You've drunk enough water, and again, water. Not necessarily. I sit here and drink iced tea all day long. Not probably the best thing because there's solutes in that. Okay, so you want to make sure that you're getting plenty of water. If you're getting plenty of water, then you're not going to release the ADH, the antidiuretic hormone, which means the collecting duct is going to be less permeable to water, and you're going to have a more dilute urine. Okay, it'll probably be back at the 200, 300 mark. Okay, and so again, you're going to be excreting more liquid compared to solutes. As opposed to here, this is going to be very concentrated with solutes with less liquid because we're reabsorbing the water because you're most likely dehydrated. Hope that makes sense.